So now we can start Unit 2, which is going to be actually talking about the different antibiotics. I'm sure you guys have been waiting on the edge of your seat to get to the actual drugs, right? Everyone likes drugs. Now we get to it. So like we said, there are different classifications. These are the main ones we'll be talking about. The first group are going to be ones that are really working on the cell wall itself. So here we have starting out is going to be our beta-lactams. The first group we'll talk about of our beta-lactams is going to be penicillin. You can see here this kind of square structure in the middle of the molecule. That's the actual beta-lactam group. That's what's going to be the business end of the molecule working on the bacteria. When you hear of someone who has an allergy to a beta-lactam, they're not actually reacting to the beta-lactam group. What they're actually reacting to, most likely, is going to be this R side chain, and this is what's going to differ between the different antibiotics. So penicillin will have a different R side chain than piperacillin will have, than dicloxacillin, but they all have this basic structure in the middle. This beta-lactam group is the same, and you'll see this with all of the beta-lactams. They have the same group. So this one is, sorry, the color's a little goofy, but essentially what's happening here is that the beta-lactam ring actually mimics two D-alanines. And so D-alanine is really important for getting this cross-linking happening with the cell wall itself. So by binding that, it'll actually interact with one enzyme in particular, is actually by mimicking this, it's going to prevent the propagation of the cell wall. So here you can see it binds to this enzyme called penicillin binding protein. And usually that enzyme is useful for cross-linking these different chains of the cell wall. And so by binding it covalently, you end up preventing the penicillin binding protein from propagating that cell wall, right? So eventually, once you have enough of the penicillin binding protein, sorry, the copy paste does not go so well here. Essentially, though, what you're seeing is that the penicillin binding protein, when the covalent linkages and enough of it has been inactivated, eventually you're going to get to a point where the cell wall cannot continue to make these cross-links. It's not going to be able to continue producing a cell wall in general, and then you're going to have a rupture of that cell wall. All the contents leak out, and now you have a dead bacteria. So if you had to guess if penicillins are bacteriostatic or bactericidal, you'd say bactericidal, right? Because it's actually killing the bacteria directly. So the first group of penicillins we'll talk about are going to be our natural penicillins, right? Monopenicillins came from mold. Probably have some growing in my fridge right now. But the first one we'll talk about is going to be penicillin G. So this is, again, our first natural penicillin. If you'll notice here, I kind of use this this mechanism for showing you guys the coverage of the antibiotics in kind of broad strokes. So again, if it's green, that means it has good coverage. If it's red, it probably has very poor coverage. And yellow means it's got okay coverage. Not great, but there are probably going to be some bacteria that's going to be good for it. So penicillin G, again, was our first one. It has pretty good activity against the gram-positive cocci, but no staph coverage. You're not going to see staph coverage with our penicillins for a few generations here. It does have some okay anaerobic coverage, except it does not cover Bacteroides, which is going to be kind of a big hole for its anaerobic coverage. So you won't see this one used by itself for say like intra-abdominal infection, right? Because it's not going to cover all the bacteria, all the anaerobes you'd really need it to. But it does become the drug of choice for things like syphilis, gas gangrene. In some cases, it used to be used a lot for meningococcus, but now we have better antibiotics to use for that. So it's not necessarily going to be used for that all the time. And then to note with the natural penicillins, you don't have really good gram-negative coverage, right? So you would not use this for something like UTI, because it's not going to cover a lot of those gram-negative bacteria that are generally causing a UTI, right? So just as an example. I'll have dosing on here. Don't memorize the dosing, right? Memorize the concepts of why the drug is being dosed the way it is. So in this case, if you see it being given every 4 hours, what does that tell you about the antibiotic? The time-dependent killer, right? Because the time-dependent, you want to keep it above the MIC as long as possible, so you want to dose it very frequently. So you'll see that with all of your penicillins, all of your cephalosporins, they're all going to be time-dependent killers. So they need to be above that MIC for as long as possible, right? Again, anytime you're giving any of these drugs, you're going to be looking for signs of anaphylaxis. Obviously, you're a little bit more worried about anaphylaxis with some of the natural penicillins, but of course it can happen with any of these antibiotics. So always keep that in mind. Note there's a few different dosage forms for penicillin. So the natural penicillin G, this is a benzyl penicillin, is generally only given IV because of the fact that when it gets in contact with stomach acid, it's not very stable. A lot of it gets destroyed, and so it's not good for oral absorption. You do have a dosage form called penicillin VK or V-potassium. This is phenoxymethylpenicillin potassium salt. It is much more stable in stomach acid. So that's the variety you're going to see given orally. So penicillin VK is the oral dosage form. Penicillin G is going to be for IV administration. There's also a long-acting dosage form. You have this benzathine penicillin, otherwise known as bicillin. This one's really nice. If you notice here, it's it's hard to tell, but it's kind of got this like kind of milky white texture to it. And this is really only going to be administered via IM administration, right? Because it comes as a suspension, and you never want to give suspensions IV because what could happen? So in general, IV solutions are being given because it's a homogeneous mixture. Everything is dissolved very evenly throughout the mixture. It's a solution. That's basically the definition of it. When you have suspensions, you have things that are much larger particles, and so you don't want to give those IV because you worry about embolus forming, right? So same reason why there's certain like an old school antidote for lead poisoning actually comes in peanut oil, and you can't give that IV because the oil itself can cause an embolus, right? Because it's a suspension. So in this case, you have a suspension here that is only given IM, and when it's injected into the intramuscular site, it's able to kind of leach the drug out over a long period of time, and so you only have to give it once. So say for instance you have a child who is being treated for something like strep pharyngitis, right? They're not going to take tablets of penicillin, right? Because they can't swallow tablets, they're too small. They are definitely not going to take liquid because they've spit it out 3 times already. So what's your other option? I'm not going to give them penicillin IV every 4 hours for strep. Like that's ridiculous. But what I can do is give an IM dose of this benzathine penicillin, and then do that one time, and then the drug will have a nice gradual long action, and I only have to dose them once, and that's it. Right? So in some cases, you'll see that certain patients will be better candidates for different dosage forms based on what you need to do with them, right? Based on those patient's specific characteristics, right? The next group of penicillins that we have are going to be our aminopenicillins. And so aminopenicillins are easy to remember because they start with an A. This is where you see ampicillin and amoxicillin. So again, these retain good activity against gram-positive cocci. Still, no staph coverage. It's important to remember that. They do have a little bit better anaerobic coverage, but still no Bacteroides. We'll see some of the different variety of these medications that pop up again have better anaerobic coverage, but right now by themselves they don't. And then they, again, will have no real activity against gram-negatives. You're not really going to be using these for a lot of gram-negative infections for the most part. So the thing you will see is that they're most often used for Enterococcus, Listeria, for endocarditis prophylaxis. So like you'll see someone who's being given amoxicillin prior to like a dental procedure if they've had a heart valve replacement because they're more at risk for endocarditis. And then sometimes you'll see it used for kind of run-of-the-mill, kind of not severe community-acquired pneumonias. So things that are you usually got to use a lot higher doses because the lungs are sometimes harder to penetrate from a drug level standpoint. So again, ampicillin and amoxicillin are 2 drugs here. As far as testing goes in drug and brand names, I know a lot of people really like to have brand names available because they remember that a little bit better. So for testing purposes, I will put the generic and the brand name. But I generally only talk in generics whenever possible, right? Unless we're talking about 2 different dosage forms of the same drug, then you might need to talk about the brand names. But in general, I would focus on the generics. But if you need to have the brand names, they'll be there for you. So in general, the aminopenicillins, and this goes for the natural penicillins as well, is that you run the risk of having some drug interactions, especially if you have things that prolong your prothrombin time. So for instance, warfarin is going to be the big one here. So we'll talk about warfarin later when we get to like a cardiovascular section. But warfarin's a blood thinner. This can potentially have increased anticoagulant effects when one of these penicillins is on board. And then there's also, has anyone ever heard of having to use backup contraception when being on antibiotics, right? If patients on birth control, right? So the reason why that is kind of interesting. I was doing some reading on it. It's probably not as big of an interaction as they actually used to think. Probably not bad advice either, though, just to be sure. But essentially what happens is that the thought is that estrogens, when taken orally, they get absorbed through the GI tract, right? They go through the liver and all of that. When they're getting excreted, they get excreted through the bile tract, right? So they go back out into the GI tract where they can then be, they can have the bile salts cleaved off by the gut flora, and then they can be reabsorbed back into the systemic circulation. So it's an idea called enterohepatic recirculation. That's something that will come up again with certain drugs. But essentially, you're having this recycling of the estrogens that keeps your levels up higher than it would be than it would be otherwise. So the idea was that if I give anything that disrupts that gut flora, you would eliminate that enterohepatic recycling, and thus your estrogen levels would drop. Probably not as big of an interaction as you would think, but nowadays there are more oral contraceptive packages that have lower doses of estrogens. So again, that already increases your risk for failure. So it's probably not a bad idea just to tell them to use backup while they're on the antibiotic course. But again, if they don't, hopefully they will not have an accidental pregnancy, but the risk is probably not as big as it was once thought. But that's at least the mechanism behind that. Other side effects you'd worry about with your penicillins and aminopenicillins, there's always some low risk for having hepatic dysfunction. Certainly you can monitor for things like your AST and ALT and bilirubin and whatnot to monitor for that. You'll see that Clostridium difficile infections are always a risk whenever you're giving antibiotics that are affecting the gut flora. It doesn't matter if it's IV or PO, you run the risk of having a C. diff infection. Certain ones will have a higher risk than others, and we'll talk about that, but just know that this is a potential risk here. Certainly rash is a possible side effect of the penicillins, and then the kind of extreme of that would be these autoimmune reactions. Things like Stevens-Johnson syndrome. You guys ever heard of that? It's a really, really nasty skin reaction where basically it's an autoimmune reaction where the patient will start out with very severe rash and eventually start to have this like skin sloughing that's happening. It can be very, very severe, very, very deadly if not caught early and treated with good supportive care. Toxic epidermal necrolysis is very similar to that and looks very similar and is treated very similar. So those are potential risks. You'll see that some drugs are going to be more at risk for having that developed than others, but this is one falls into that category. Certainly, there can be some renal issues that can pop up here, and then you can also have some blood dyscrasias, things like anemia, thrombocytopenias. That's going to be, kind of in addition to the risk you run with the anticoagulant interaction we talked about just a minute ago. So as far as contraindications go, things are relative or absolute. If someone says they're allergic to penicillin, again, you're always going to ask, what was the reaction you had? Was it diarrhea? Was it an actual, my throat's closing up kind of thing? I can give you guys a link to an article that talks about this. And again, depending on who you talk to, especially if they're like older school physicians and things like that, they're going to be like, well, they say they're allergic to penicillin. I'm never going to give them anything. Never going to give them a cephalosporin. Never going to do any of that, right? Probably not actually that big of a risk. So essentially what it comes down to is that back in the day when they were producing cephalosporins and producing penicillins, they're using bacteria to do it, and there would actually be cross-contamination where you'd have some bacteria producing a little bit of cephalosporin that would get into your penicillins, kind of like Reese's, or you get peanut butter in your chocolate in your peanut butter kind of thing. Same thing was happening here, and so there was a higher cross-reactivity rate that was occurring. Nowadays, though, we have much different cephalosporins. We have things like 3rd generation, 4th generation cephalosporins. The actual cross-reactivity rate to someone who has a true IgE-mediated type 1 anaphylactic reaction to a penicillin is very, very low, like less than 1%. So in general, they have a true penicillin allergy. You can generally get away with giving a higher generation cephalosporin. We'll talk about those in a little bit, but just know that risk is relatively low. But depending on who you talk to, they may not be working with the most up-to-date information. So if your other teachers say otherwise and that's what they're testing you on, then just listen to them. But clinically, this is what we do. And so a lot of cases, like I'll have docs who are really skittish to try it, and they'll say like, the patient doesn't remember what their allergy was. They just have been told all their life that they're penicillin allergic. You run into that quite often. And so I say, well, okay, here's what we can do. Give them a dose here. Watch them for 30 minutes. If they don't have a reaction, they send them on their way and they're good to go, right? Just remember, delete that allergy out of their chart is the big thing to remember there. But so I've gotten away with kind of allaying some people's fears by just saying, hey, give a test dose here, see how they do. If it's a true anaphylactic reaction they're going to have, they should have it right then, and generally you're good to go from there. Again, dosing considerations for penicillins in general, look at renal function. This is huge for all of your penicillins. You need a dose based on renal function. So again, if they have a significant renal dysfunction, creatinine clearance is dropping, you need to change how you're dosing that. So maybe instead of giving it every 6 hours, you're going to give it every 8 hours or every 12 hours. You talked about the rash. Diarrhea is also a possibility. And then as far as monitoring goes, again, looking at renal function, hepatic function in your platelets as well, potentially. So how do bacteria become resistant to penicillins? Essentially, one of the ways that they can do that is by producing a new enzyme called beta-lactamase. Beta-lactamase is going to come and cleave that beta-lactam ring, and then when it cleaves open that ring, all of a sudden the antibiotic is no good anymore, right? Can't work against the penicillin binding protein because it can't make that covalent linkage anymore, okay? So to overcome that, we developed some beta-lactamase inhibitors. So as you might imagine what they do, they inhibit beta-lactamase. Pretty easy. And so essentially these are molecules that have no activity against the bacteria themselves. They have no antibacterial activity, but they basically keep the beta-lactamase busy while your penicillin goes and does its thing, right? So the three that you'll see being used clinically include sulbactam, which is put together with ampicillin to make unicin. You'll see tazobactam is paired with piperacillin to make zosyn. And you'll have clavulanate or clavulanic acid, two names for the same thing, put with amoxicillin to make augmentin. I'm sure everyone's heard of augmentin, right? So that's your most common example of a beta-lactamase inhibitor being mixed with your penicillin. So when I add, oh, go ahead.
So why would, like, for example, I've been prescribed augmentin, I think, but anyways, but like, why would a physician give augmentin unless they know that patient, right? Like, unless they knew that they had a resistance before.
I'll talk about that in just a second.
Okay.
It's a good question though. So when you add an aminopenicillin to a beta-lactamase inhibitor, you start to increase its coverage. So you're going to be able to treat different bacteria, a wider range of bacteria, by adding on that beta-lactamase inhibitor. So you start to see that you have better anaerobic coverage, especially things like Bacteroides are starting to now be covered. It will cover MSSA, so that methicillin sensitive Staph aureus can be covered by this. And so the place where this really works very well is going to be in places where you're worried about gram-positives and anaerobes. And so things like skin and soft tissue infections could be a good thing for that. Diabetic foot infections, and certainly bites and intra-abdominal infections could be another source as well, right? So and things like, if I was worried about something like like an aspiration pneumonia, if I'm worried about someone aspirating gastric contents, that'd be another case for something like ampicillin and sulbactam being a good option for that, because it has a broad enough coverage they can get the most likely organisms that were coming up from my gut, including the gram-negatives and the anaerobes. So your question, is saying like, well, how would a provider know whether or not to prescribe something with a beta-lactamase inhibitor or not? One, based on guidelines. So say, for instance, if you're looking at certain types of infections, like you're looking at, say, like otitis media, in some cases, if your rate of resistance is already high enough based on your community, if I know all my strep pneumo is going to be really, really resistant to just amoxicillin by itself, then you may bypass amoxicillin and go to the augmentin, right? Or if they've had previous courses with amoxicillin and they still have the infection, then you may add on the clavulanic acid, and now you have broader coverage. You may be able to overcome that resistance, right? So there's a couple of different reasons why they would do that. But again, if you're worried about, the biggest one is going to be patients that have previous courses of more narrow spectrum antibiotics, and you need to bump up your coverage, and the infection hasn't resolved itself. It's probably one of the big ones. Or if you just need that increased coverage. So certainly someone who's coming in for, say, like an animal bite or a people bite, something like this would be your more go-to drug, because again, augmentin is an oral dosage form. I can give them a dose in the clinic or the ER and send them home on it. That'll cover all those anaerobes they might have growing in that wound. Say people bites, and it happens more common than you think. So just remember that. Okay, so the next group of penicillins we'll talk about are going to be our penicillinase-resistant penicillins, otherwise known as our anti-staphylococcal penicillins. All right, so we said by adding on a beta-lactamase inhibitor to the aminopenicillins, they started to get some MSSA coverage. Now we just have a group of penicillins that work against staph themselves. So this is the one that methicillin would have fallen into, but we don't really use that clinically anymore. So the three big ones you're going to see being used include nafcillin, oxacillin, and dicloxacillin. Okay. Again, these are designed solely to cover MSSA, and they really have a lot of decreased coverage to all other types of bugs. So you rarely will see these being utilized as empiric therapy for anything, unless you're really, really sure that Staph aureus, MSSA specifically, is going to be a causative organism, right? A lot of times what I'll see is that patients will be on more broad spectrum coverage, and then once your bacteria comes back and cultures come back and it says, hey, it's MSSA, I will see them narrow down to use one of these because it has such a narrow spectrum that you're not really worried about developing as much resistance, right? So this is a good kind of de-escalation antibiotic to go to if it's just MSSA that you're dealing with. Again, you're going to see the adverse reactions, drug interactions, monitoring is all going to be very similar to your other penicillins. And then you have your Antipseudomonal Penicillins. Really, the only one that falls in this category is going to be Piperacillin tazobactam. So in general, when I'm asking questions on tests or quizzes and things like that, I'll generally be focusing on kind of broad strokes like, is this drug going to be good for this type of infection, right? Is this going to be good for a gram-positive? And so the way I'll pose, I'll pose it is, a patient comes in for, say a skin and soft tissue infection. You're really worried about covering for MRSA. Which of these antibiotics will be good to cover that? Right, so questions like that are generally how I try to go with it. Try to make it a little bit more clinically based. And so things that have MRSA coverage and things that have Pseudomonas coverage are really good things to note because they'll probably come up on a test question at some point. So just note that. So your only Antipseudomonal penicillin here is going to be piperacillin with tazobactam. I've never actually seen piperacillin given by itself, so I'm pretty sure it's been discontinued. So you really only see Zosyn being used out there. This is a really, really good broad-spectrum antibiotic. It maintains good gram-positive coverage, including MSSA. So if you have something like an MRSA infection, this is not going to be good. In fact, there's really no penicillin you're going to give that's going to be good for MRSA. It has really good gram-negative coverage, including Pseudomonas. So hint, hint, remember this one. And it also has good anaerobic coverage. So this is really good if you have something like a really complicated appendicitis, like a ruptured appendicitis. Like this is a really good single drug I can give for something like an intra-abdominal infection because I know it's going to hit my gram-negatives, I know it's going to hit my anaerobes, and it's going to get everything else that's out there. So this is a really broad-spectrum antibiotic. You also see it used for a lot of nosocomial infections, including pneumonias. So this is another good one for that. Or if you just have a polymicrobial infection, this is really going to cover a lot of things. So this is one of your gorillacillins, as you'll see them being termed sometimes, because it covers really everything, right? So this is a good first drug to go to if you're really worried about a more serious infection, and then you scale back down from that, right? So this is one you would give to like your 90-year-old grandma coming from the nursing home, right? Not something you give like to your 2-year-old coming in for a strep infection, because you can get away with a lot lower guns. But if you're really worried about a really sick patient, worried about resistant bugs, this is one of going to be your go-to drugs, right? Again, notice here, this one's given every 6 hours, again, showing you that it's going to be a time-dependent killer. Again, renal function is going to be really important here. You do need to renally adjust for these. So you'll see sometimes the same dose being given every 12 hours, every 24 hours, depending on how bad their renal function is. And the monitoring, again, is going to be the very same as all your other penicillins. Okay, any questions on penicillins? Moving on, we have our cephalosporins. Notice here that the beta-lactam ring looks very, very similar. Has this extra ring that's added on here, and then the R side chains as well. Again, a lot of reactions are going to be coming from the R side chains. And again, as you get higher in generation of cephalosporin, we'll talk about what that means in a second, you'll see that they get more and more farther away from the natural penicillin structure, and so you're less likely to have reactions, cross-reactivity between those. So cephalosporins, kind of their place in therapy is that, one, they have really good cerebrospinal fluid penetration, and so if you're worried about empiric coverage for things like meningitis, this is going to be one of your go-to classes of drugs. Like I said, penicillin cross-reactivity is generally pretty low, especially the higher up in generation you get. And you'll notice here that the monitoring is going to be very, very similar to what you see with your penicillins. Yes?
Can you explain this generation?
Yep, I'm going to get to that in just 1 second. Yep. I was trying to keep you guys in suspense until I get to it. Yeah. Yes?
So since the penicillins act by affecting the cell wall, do cephalosporins work in the same way? Is it
Exactly.
The cell wall as well?
Yep, they're going to be working on those penicillin binding proteins and doing the same exact thing. Yep. So again, these would be bactericidal as well because they're affecting that cell wall synthesis. So their spectrum of activity is going to change based on generation, like I said, I'll mention in just a second. And notice that there's 2 of them that will have antipseudomonal coverage. There's ceftazidime and cefepime. I'll talk more about this in general, but really the one you should remember that has antipseudomonal coverage is going to be your cefepime. I'll talk about why that is a little bit later. The majority of these will be renally eliminated. So again, you do want to worry about renal function, adjusting for that, with one notable exception, as I'll mention when we get to it. So the generation progression. So you'll have things that are first, second, third, fourth, and even now a 5th generation of cephalosporin. And so it's important to remember which generation a cephalosporin falls into, because it's going to change the kind of coverage it's going to have, which antibiotics or which bacteria it's going to be covering. So as one moves up in cephalosporin generation, you're going to be seeing increasing gram-negative coverage. On the other hand, you're going to have decreasing gram-positive coverage until you get to the 4th generation, and then it starts to pick back up again. Okay. So we'll see what this means in practice, but in general, that's what you're going to see. So the more kind of hardcore gram-negative infection you think you have, the higher generation you're going to want to go, but you're not going to be focusing on it for sole coverage for a lot of gram-positives, right? So you'll see, like for significant abscesses and things like that, we worry about really a lot of gram-positives. Like you're not going to see a late generation cephalosporin. You're going to be seeing maybe more like an early generation because it retains a lot of that gram-positive coverage. Okay, so I'll show you what that means when we go through the actual generations. So the first generation, we'll talk about the two main drugs. And again, there's going to be more cephalosporins out there than you'll ever actually see clinically. So I try to focus on the ones you might actually see out there in the clinical world. Otherwise, you could drive yourself crazy trying to memorize them all. The two big ones you'll see, you guys are already going to go crazy with these. So the two big ones you'll see in this first generation are going to be cefazolin. Some people say cefazolin. I don't really care which one you say. Otherwise, it's Ancef. And then you also have cephalexin or Keflex. I'm sure you guys have heard of Keflex, right? Yep, pretty common one. So Ancef is used a lot for surgical prophylaxis. So again, you'll see this used prior to surgery and then usually for 2 doses afterwards for a full 24 hours of coverage to prevent surgical infections. Sometimes you'll see it used for MSSA, so this does have coverage against methicillin-sensitive Staph aureus, but notice no MRSA coverage. We still haven't really gotten to an antibiotic that works on MRSA yet. Cephalexin is going to be good for UTIs and some skin and soft tissue infections. Resistant rates can be your mileage may vary on how well you can use using cephalexin for skin and soft tissue infections because it's used so frequently that you see a lot of resistance pop up. So usually what you'll run into is you'll have either you have a kind of a clindamycin kind of place or you'll have a cephalexin kind of place. And so one's going to be really resistant to one and not the other, and you're going to have to figure out which one you want to use. So where you go to work, you may just ask them like, hey, if you have a patient with cellulitis, what are you most likely to use, right? Clindamycin or Keflex, depending on what their resistance patterns are. One thing to note with all cephalosporins, and this is kind of a big hole in their coverage, is that none of them cover Enterococcus, which means you're never really going to see a cephalosporin used for an intra-abdominal infection unless it's being added on with something else that does have coverage against Enterococcus and does have coverage for anaerobes, right? So in general, you're not really going to see any anaerobic coverage, and you're not ever going to see enterococcal coverage with your cephalosporins, okay? Just for any generation. But again, here you're going to see some gram-negative coverage, but that's only going to get better as you get higher up in generation. The next generation will be our second generation agents. This is going to be including things like cefoxitin, cefotetan, cefuroxime, cefprozil. Again, more gram-negative coverage in your first generation agents. Start to see more H-flu coverage, more Enterobacter coverage. Sometimes you'll get some pretty rapid resistance to that though, but certainly things like Neisseria, Proteus start to get covered. You'll see this being used a lot for UTIs, upper respiratory tract infections, surgical prophylaxis. This is probably the least used generation that I see clinically. But it's still important to know because you'll still see them used. Cefuroxime certainly can be prescribed with some regularity. Third generation, this is where things get a little more interesting, at least on the inpatient hospital side. So you have four main agents that fall into this category that I see being used. So you have ceftriaxone, otherwise known as Rocephin. You guys have heard of that, right? Okay. Rocephin is really good IV agent. It's IV only. This is the one notable exception that does not require renal adjustment. Okay. This one is primarily metabolized through the liver. And so you don't really need to worry about renal excretion in these cases. The other thing with it is that it has a really long half-life. So even though these are concentration or time-dependent killers. Because just like your penicillins, these are time-dependent killers, right? You're giving them pretty frequently. Same mechanism of action, same type of killing is going on here. Ceftriaxone has such a long half-life, you can get away with giving it just one time a day. And so if you think about it, ceftriaxone, one time a day, that's how often you really need to administer it. You'll see some cases where you give it every 12 hours, especially in like meningitis and things like that. But this is really your go-to IV third generation cephalosporin. Something to note here is that you don't want to use this in the first 30 days of life. So it's contraindicated for neonates to receive it. And the reason why that is that there's serum proteins that can bind drugs, right? Things like albumin can bind drugs and alpha-1 acid glycoprotein. You guys talked about that in your first pharm course at all? Okay, so there's serum proteins, things like albumin that actually bind drugs, right? And so you can have interactions where things can displace one another, and so sometimes that can lead to toxicity. So a really good example would be something like phenytoin, which is an antiepileptic, 90% protein bound to albumin, 10% free, right? And anytime you have free drug, that's pharmacologically active drug that can work on the tissues. If it's bound up by the protein, it can't really work on anything. If you have something that comes on and kicks that drug off the protein, you have an interaction there, now you have more free drug, we're likely to see toxicity that develop. So what we're seeing here with ceftriaxone being given to neonates is that they have a lot of bilirubin, right? So if I were to give ceftriaxone, it actually competes for the same binding sites, and they end up having them kick off all that bilirubin. All of a sudden they get really jaundiced, right? So that's why we can't use ceftriaxone in those cases. And so the alternative is to use cefotaxime or clafuran. So if you have a kid who comes in for like neonatal sepsis, you want to use cefotaxime in order to cover for all the different bacteria you're looking at, but it won't have that same interaction with the bilirubin. Make sense?
Mustaphin can be given IM as well, right?
It can be given IM as well. Yeah, it hurts like a mother. You'll see that different concentrations of drugs will be used based on where you're administering it. So in general, you want to administer things in a more concentrated form in the IM sites because you can only accept so much volume, right? I can pump people full liters of fluid IV, but IM, that's going to hurt really bad. So you use a lot more concentrated concentration of Rocephin, and sometimes you have to give really big doses. You might have to get 2 shots at the same time or something, but yeah, certainly can give it IM. You also want to avoid mixing it with calcium. It can actually cause precipitation to occur, which can lead to either occlusion of a line or it could lead to embolus in the patient, which is really bad, so you don't do that. You have ceftazidime as another 3rd generation. This one does have Pseudomonas coverage, but clinically you never want to use it for Pseudomonas because the resistance develops very, very quickly to it. So there's really kind of rare instances where ceftazidime is a recommended antibiotic. The only cases where I've seen it really used, and again I'm coming from more of a peds realm, is for kids with cystic fibrosis. I've seen certain ones that will grow really kind of oddball bacteria because their lungs are just full of thick gunk and they grow all kinds of weird stuff. And so there's one that just happened to be ceftaz sensitive that we use for them. But in general, don't worry about this one as far as Pseudomonas coverage goes because clinically you don't use it. And then Ceftonir is going to be your oral 3rd generation cephalosporin of choice. So this is a really good one. So if you were to have, say, a patient who's inpatient receiving, say, ceftriaxone, and you want to send them home, but they still need to finish up their course of antibiotics, switching them over to one of these oral versions, like either Cefixime or Ceftonir, is going to be your go-to oral alternative. And so anytime you can give something oral instead of IV, you want to do that because it cuts down infection rate and things like that. Usually a lot cheaper too. So again, notice this has better gram-negative coverage in your 2nd generation, but it loses more gram-positive coverage. And it has some extra coverage against things like Serratia and Moraxella. So again, just note ceftriaxone, again, you'll see this used very, very frequently for lots of different indications. Certainly, though, it's one of your go-to drugs for meningitis since it has good CSF penetration. It's able to get to the site to work pretty effectively. Yes?
So 3rd generation loses gram-positive coverage?
It loses more of it, but you'll see things like Rocephin still has good coverage for like strep pneumo and things like that. It's just not as broad a coverage as you would see with like a 1st generation. So you don't really see these used for like skin and soft tissue infections, right?
But the 4th generation, you won't see that.
You'll start seeing gram-positive coverage pick back up in the 4th generation. Yeah. Okay. So your 4th generation cephalosporins, the big one here is going to be cefepime. Those are known as maxipime. So this is another good another good broad spectrum antibiotic. So the way I think about these two is I think piperacillin tazobactam or Zosyn is very, very close in activity to cefepime. The only difference is that my Zosyn has anaerobic coverage. This one does not. So if I'm not worried about anaerobes, then this is the better drug to go with, right? Because then I'm not using such a broad spectrum antibiotic. I'm not worried about as much resistance. So this is why this is a really good drug of choice for things like neutropenic fever. So if you have like a patient who has, say, who's on active chemotherapy and they're neutropenic, or if they have, have AIDS and they have really, like end-stage AIDS where they have, like, no CD4 cells left, these are going to be better alternatives for them when they come in. Because, again, when they're coming in with fever and you can't really cite a source for where it's coming from, you need to use broad-spectrum antibiotics to cover all of that. So this is a good option for that. You'll see it used a lot for things like nosocomial infections as well, things like hospital-acquired pneumonias, ventilator-acquired pneumonias. That's what those acronyms are. And then this one does have Pseudomonas coverage. So again, if you're worried about Pseudomonas, this is a good one to go to. And then we even have a 5th generation cephalosporin. So this is one of the newer ones. I've never actually seen it used in practice, but you guys might see it, since you'll be out there. So ceterolene or teflaro. This one's really kind of interesting because it has decent gram-negative coverage, has good gram-positive coverage, still no enterococcal coverage. Right, so still no abdominal infections unless this was something else. But this one actually does have MRSA coverage. So this is our first drug we've come across as MRSA coverage. And then it also cover Pseudomonas as well. So it's got a weird kind of coverage pattern. You usually don't see things that are really good against gram-negatives and will treat MRSA. Usually you get kind of one or the other, but this is one of those kind of rare exceptions. So the things that the FDA approved this for include community-acquired pneumonias and then skin and soft tissue infections. Again, remember these in general need to be renally adjusted. Really, ceftriaxone is a big exception to that rule. The other new kid on the block as far as cephalosporins go include ceftolozane and tazobactam. You guys remember tazobactam from just a few slides ago, which is a beta-lactamase inhibitor. That's right. Yep, you guys got it. So again, it just helps to broaden the coverage of the cephalosporin. So again, has good gram-negative coverage. This one does not cover MRSA, so really that's ceterolene was the only one that really did MRSA coverage, but it does retain some pseudomonal activity. And notice here that because we added on the beta-lactamase inhibitor, now we have better anaerobic activity here. Okay, so this is one of the few cephalosporins that actually has some decent anaerobic coverage. So this one is going to be FDA indicated. Notice here that they say you can use it for complicated intra-abdominal infections, but you need to have it plus another drug, so plus metronidazole, which is another common one we see used for intra-abdominal infections, because it needs to have enough coverage in order to help get all of those intra-abdominal bugs. And even though this does cover some anaerobes, it's not really going to get the full gamut of it like you would see with the addition of the other drug. Yes?
When this is complicated urinary tract infection would be an example of that. If you were to ask a question for this drug, the patient has a UTI, what would be a complicated one?
Complicated would be if you're having like pyelonephritis, so if you're getting a much more involved UTI, if you had failed previous courses of antibiotics, that might be an indication to kind of up your ante as far as like the coverage you're going for, because usually like UTI can get away with using something like a cephalexin, for example, but if they fail therapy with that, then obviously whatever I was trying to cover for wasn't being killed by that. So I now need to step up my game, and you could consider that a complicated UTI at that point. Yeah. There's probably some other indications, but I don't know off the top of my head.
I have a question. So as far as cephalosporin, ones with generations, is the active part of it the beta-lactamase or the beta-lactamase and the dihydroinosine?
Yeah.
What is actually different structurally between them based on the first generation?
A lot of it has to do with the R side chains being different, and again, as you get further up in generation, they get more and more kind of synthetic and not really so close to that kind of natural penicillin type shape. So if you look at like the aminopenicillins and like first generation cephalosporins, they look more similar than it would be if you compared that aminopenicillin to like a ceftriaxone or cefepime, right? So those are getting more different, and so the mechanism of resistance isn't just beta-lactamases. There's other ways they can get resistance to it as well. So things like changing the penicillin binding protein can change the actual receptor site changes. So that has an influence on the activity and the binding and things like that. So that's again where the side chains kind of come into play there. It's a good question. Okay, so I think I'm going to cut it here. Any questions before we go? Yes.
Just flashback to the last slide. I heard you say because there's an added beta-lactamase inhibitor, it has better, did you say anaerobic activity?
Yeah, so it has some increased anaerobic activity. But it's still not super great because it's only indicated if you're using it in conjunction with metronidazole. So it's like, well, I can get away with using piperacillin and tazobactam. That has great anaerobic coverage, and I can use one drug instead. So I don't really know what the actual place in therapy this is going to be. But again, I guess more antibiotics is better than not any because we need something to treat some of these super bugs out there. Well, any other questions before we wrap up? All right, we will continue with this and then get into the next section, hopefully, if you guys have not thrown me out by then. Otherwise, I will see you guys next week. Oh, yes.
Are you going to be pulling from the book at all, or just
it's a new book to me, so I will probably consult it, but I'm not going to pull probably a ton from it, at least this time around. So really, if I'm testing off anything, it's going to be coming from the slides.